Welcome to this edition of Ethics Rounds, June 25th, and the CME code is 15433. And just want to remind everyone, these Ethics Rounds are sponsored by the Ethical Advisory Committee at the University of Maryland Medical Center, and just like to remind everyone, we're available for consultations 24/7, and these are the various ways to contact us. The cell phone number is my cell phone number. Feel free to call me anytime. The page operator, or you could put an order in Epic, and there's always Tiger Connect. Again, we offer 1.0 CME credit, accredited by the University of Maryland School of Medicine, and you have to register only once to obtain credit, and then you could use the Cloud CME app on your phone. If you have any problems, just send me an email and I'll make sure you get the credit. Objectives of this rounds is, upon the completion of this activity, participants should be able to discuss ethical dilemmas in clinical practice and also use an ethical framework for solving ethical dilemmas. I also like to tell everyone we're in the midst of doing a survey study in the intensive care units at the University of Maryland Medical Hospital. It's a study about perceptions of the ethical decision-making climate among clinicians regarding the appropriateness of end-of-life care. The aim is to identify factors that impede consensus among staff regarding appropriateness of end-of-life care. And we're recruiting physicians, nurses, advanced practice providers, consultant fellows, and residents in the ICUs and also in the IMC. It's a 20-minute survey. Responses are anonymous, and we offer two incentives to enter the lottery for a $50 Amazon gift card or an iPad Pro, a lottery which will be held at the end of the study. Oh, let me right. Okay, good. So if you're in the ICU, working in the ICU, even as a consultant, please watch out for the signs to fill out this important survey. Now, all right, I think we're ready to get started. Oh, by the way, this survey is being done at this hospital, the University of Maryland Medical Center, but we actually trying to get to do this survey at the other hospitals in the UMMS system. So the first case, should a patient with refractory heart failure be permitted to discontinue his medications although he appears to lack decision-making capacity? We have a 49-year-old male diagnosed with pulmonary hypertension called pulmonale, pericardial status post-pericardiocentesis with a drain in place. He has a past medical history of end-stage renal disease and hemodialysis. He had a kidney transplant that failed. He also has bilateral renal cell carcinoma and bilateral nephrectomies. Patient was admitted to an outside hospital with heart failure exacerbation and then transferred to UMCC 2 weeks ago to optimize treatment. His hospital course was significant for increasingly refractory to medical management with acute and subacute complications of chronic disease. So the plot. Early one morning at approximately 2 a.m., physician on call was informed by the patient's nurse that the patient decided that he wanted his epoprostenol therapy to be stopped. He no longer wanted to be laying in the hospital bed. He has been in the hospital for 2 weeks without any improvement. He asked to have all his treatment stopped, including chronic renal therapy or dialysis, and also the heparin infusion to be stopped so he could leave the hospital. He intends to walk out of the hospital, but was told that his deconditioned state would make it very him to
Yeah, see, that one ain't even working at all.
for him to walk. He acknowledged that he would probably need to have a wheelchair then. Now, according to cardiology, the patient has been refractory to further treatment, and in all likelihood, further treatment is probably futile. Patient appears to lack capacity to make decisions, as he does not appreciate that he will die if medicines and interventions are discontinued. So what should we do now? So should the medications and interventions be discontinued? That is the question. And so we have to figure out whether he really does have decision-making capacity. So let's, I have a new feature here, a quiz. Why don't you all join the quiz? Either scan the code that you see, or go to slido.com and there's the event code, but it's probably easier just to scan the QR code. So join the quiz. Okay. All right. And so what is not a requirement of decision-making capacity? Understanding of information, appreciation of the situation, cognitive ability to process the information, adequate memory. Choose one choice. Okay, so most people said adequate memory, 85%. That's a very large majority, and that is the correct answer. You know, we have these tests assessing memory, but memory is not an important requirement of decision-making capacity. Understanding, disclose information, appreciation of the situation, and the cognitive ability to process the information and weigh options. So that's the correct answer. And here's our leaderboard.
It's nice to be watching the video.
Okay. And this is a competition. Katie is out in front. She answered the question in 8 seconds. The competition is based on correct answer and the speed. Okay. So this is the current leaderboard that we have here. We have 2 more questions. So everyone has a chance. All right. Let's see. So ethics was called in. I spoke with the patient. He is alert and expressed his desires to leave the hospital. When I asked him why he wanted to leave, he said he has given his doctors the last 2 weeks to solve his riddle, and he has not improved. I told him he's receiving several drugs to maintain his blood pressure, and if this continues, there's a high likelihood of death. Well, he said, well, 20 years ago, he was told he only had 5 years to live, so he is at peace with the prospect of death, although he does not believe he will die. I asked him if his medications were discontinued, would he want the medications restarted if his condition deteriorates? He said he would want the medicines to be turned off slowly so that his body could get used to not having the medicines. So the analysis, well, patient with severe cardiac failure, which is refractory to therapy. It appears that continued therapy is medically ineffective or futile. Although he recognizes that he might die, he does not believe that death will occur after discontinuation of his medications. There is a concern as to whether he has full appreciation of his current situation. He believes he will not die after discontinuation of his medicine, but he does realize that he has advanced disease and he is at peace with the prospect of death. So does the patient have capacity to refuse therapy? Well, I want to emphasize that when we determine capacity, we use what's called a sliding scale determination of capacity. So what the heck does that mean? Well, the more a decision has adverse implications for patient welfare, so let's say this end of the scale has a high likelihood of that the decision will have adverse implication for patient welfare, the more certain we would want to be that the patient have decision-making capacity. So we would spend more time with the patient and understand his reasons. So his decision to discontinue life support actually advances his welfare insofar that since continued treatments are medically ineffective, hence continuation of such futile treatments actually opposes his best medical interest. And so if you want to say that at this end of the scale, discontinuation of the medicine actually advances his welfare, then or I'm sorry, if one wants to say that continuation of the medicine is opposed to his welfare, so actually we want him to make a decision that advances his welfare, and he actually is saying he doesn't want the medicine, so he's making a decision that is congruent with his welfare. So what do you think of that reasoning? People could unmute themselves, and what do you think?
May I ask a clarifying question?
Absolutely.
You mentioned in one of your slides that the patient said something about turning off his medication slowly. What did he mean by that? And is that even feasible in this situation?
Well, I mean, one could turn off his drips slowly in the sense of titrating it down. Mm-hmm. But essentially, that was in response to the prospect that he would die if it turned off cold turkey.
Right.
Regardless whether it happened whether we would turn it off over an hour or over several hours, it would probably have the same effect. So essentially, we have a patient who is now dependent on his medicines, but it's not doing him much good. Right. And the cardiology folks were not what's the word? I'm blanking. Optimistic.
Optimistic?
Yes, right. Optimistic. I should use that word more often. That he would ever be able to get off his medicines, okay, and leave the hospital.
The thing I'm wondering is if he imagines this as he's taking, a cocktail of things, right? And can sort of, like, you remove one and then remove another and then remove another, he could sort of see how his body reacts and then make a further determination. That to me seems somewhat reasonable, right? And would not presumably be indicative of a lack of capacity. But if he's basically saying, I want you to turn it down, and basically all we're talking about here is, well, we can turn it down to the point where it's no longer doing what it needs to do. So you either have it and have enough of it, or you don't, right? There's no, there's a threshold that we cross, at which point we go from does what it's supposed to do to does nothing, right? And he's basically saying, do something different. That seems to be a lack of understanding of what it is we're talking about.
Although I guess what I would say about this patient, I think I may have taken care of him, is it sounds like, at least from the therapies that were mentioned here, that it's not clear that some of the continuous therapies were really providing much benefit anymore.
Right, Catherine. Thank you for those thoughts. So, Ian, when you said it's not doing what it's supposed to do, we have to clarify, what is it
Right.
Supposed to do?
Right.
Is it merely to keep a stable blood pressure? But if he can't get weaned off, I mean, then what's the point? And
right.
So actually, we spend we get to the point where when we think treatments are futile, we have to convince the patient or the family that it's not doing anything, and maybe we should opt for comfort care. And here we have a patient who is coming to that conclusion for us, except for the fact that he thinks that not only are the medicines not doing anything for him, but he actually thinks he won't die.
Right.
Or he's optimistic that he won't die. And I think that's the struggle that the cardiology people were having, that he appears to lack capacity in the sense that he doesn't realize that he might die without the medicines. So having said that, is that an inhibitory concept for us to listen to him? So in the final analysis, why don't you go to your chat box and vote yes or no? Should we turn off the medicines or keep going with the medicines? What do you think? Let me see the, how are you guys voting in the chat box? Okay, turn off, turn off. Okay. Stop, turn off. Yes, turn off. All right. All right, yeah, well, yeah, support them from the palliative care team. Okay, so I think it's fair to say that people are saying turn it off, and that is actually what happened. All the fusions were turned off. Patient looked ill this morning. This is from the Epic Note Dysmic, poor mentation. He insists that he feels fine and continues to say he wants to go home. He does agree with home hospice, and the patient's sister is willing to take the patient home for hospice, wait till Monday. However, he continued to have decline in his mental status and his vital signs, and eventually, I think it was Sunday morning, he became bradycardic, and he died early that morning. Any other final thoughts with this case? Very unusual case, but I think we made all the right moves, and and thank you all for validating that action. Okay, good. So the next case, who can serve as the patient's surrogate decision maker? 65-year-old female presented in last February, history of right-sided basal ganglia bleed with intraventricular hemorrhage and midline shift. secondary to hypertension. Previous hospitalization complicated by tracheobronchitis, left groin, hematoma requiring rehab, admission, CDA, Crohn's disease, dementia, depression, COPD, peripheral vascular disease, hepatitis C. In February, when she was admitted, she had a peg and a trach. At that time, instead of going to a long-term care facility, the family decided to take the patient home as they thought that they would be able to care for the patient. I think the daughter was in the healthcare field, a nurse, I think, and thought that they didn't want mom going to a long-term care facility. But a few weeks after discharge, the patient presented in March with coughing and tooth feeds from the tracheostomy and concern for aspiration. The plan was for the patient, the initial plan was for the patient to return to the original living arrangements with the but the daughter said she could no longer care for her mother now. And according to palliative care, and I quote from the chart, patient prognosis per palliative care is less than 6 months. It has been difficult reaching the family who have expressed conflicting interest in hospice versus long-term care placement. Social worker is assisting with family discussion and has been attempting to reach both daughter and son, who are the next of kin. So the plan is now for discharge to the long-term care facility. Patient has been medically stable for about a week, but the medical team has found it difficult to make contact with either the son or the daughter. Ethics consult placed at the end of May, and it was our determination that optimal placement for the patient would be hospice. Social worker was able to contact the son, who seems interested in the hospice option. Attempts to reach the daughter remains unsuccessful. According to Maryland law, the son and the daughter have equal priority in regards to surrogate decision-making. However, if the daughter remains unavailable, the son should be considered the primary surrogate decision-maker. Recommendations continue with attempts to contact the daughter. However, if such attempts continue to fail, then discharge planning should occur with the son by tomorrow. But then we started having difficulty to contact the son. Although one knows that a son and daughter exist, should guardianship soon? I'm launching a poll on.
Turn the light.
Okay, so should guardianship be pursued?
I think yes.
The poll is going on. Okay. All right. And I'll give you a few more seconds to vote. All right, so you see the results of the poll. A majority said yes, guardianship should be pursued, 62% versus 38%.
Ivan Zama here. I wanted to make a quick comment.
Yes.
I did vote no, and this is my rationale.
Oh, well, you said you did vote no or did not?
I voted no, and this is my rationale. I think there's one avenue that we could still try to reach the son and the daughter before we pursue guardianship, and that avenue is sending, for instance, non-emergency police, because we know where they are, for non-emergency police to go check on them and get them in before we see guardianship. Now, if the non-emergency police goes and they still refuse to come, at that point, I will see guardianship, because I've had a few instances like this that I've sent the non-emergency police and the family did show up. So I would want to pursue that route first.
Right. Okay. That's a good point. We could send the police out. But it, so, okay, done. They don't open up the door or they're in Florida now, who knows, but it appears that they're somewhat avoiding the situation. So even though we know a son and daughter exist, one could still pursue guardianship. And the point I want to, I have another poll here. Which of the following is not a relevant ethical principle in this case? And so get ready to vote again. Beneficence, non-maleficence, autonomy, or justice. Okay. And 75% said justice is not a relevant ethical principle. Beneficence, non-maleficence, family autonomy, justice. Well, actually, maybe this is a trick question. I thought family autonomy is not a relevant ethical principle in the sense that they're not available. I guess, tell me more about justice. Here's our leaderboard. I don't know why it changed. No one got this right, but why is justice not a relevant ethical principle here? Or why is it even on the table? Somebody voted for justice. Well, in my reasoning, I guess one could say family autonomy is relevant in the sense that in this case it's not relevant because they're not available. So let me unpack the term availability. When is a surrogate considered not to be available? So according to Maryland law, availability means the right, justice in the eye of the beholder. Sometimes, or a lot of the times, availability is meant that we're unaware of the existence of any family members. However, it could be that we cannot ascertain the whereabouts of the surrogate decision makers. A healthcare agent has not responded in a timely manner to written or oral messages from healthcare providers, and that was happening in this case. We're trying to contact them, but they're not responding. And that happens a lot where voicemail box is full, they never call back. And at that point, one could say that surrogates are not available, and one could start filling out the papers to appoint a court-appointed guardian. Availability could also mean the decision maker is incapacitated or the healthcare agent is unwilling to make decisions. One point about this last bullet point here is that frequently a healthcare agent doesn't want to make decisions, and I hear the notion that that person then chooses who should be the decision maker, and that's not the correct move. A surrogate can't choose who could take their place. You have to go according to the priority list in Maryland law. So some thoughts about surrogate decision making. So getting back to this case, so our recommendations was that Due to difficulty with engaging the son and the daughter regarding goals of care, it appears that the siblings are not appropriate surrogate decision makers because they were largely unavailable. Hospice appears to be in the best interest of the patient. These conclusions should be entered in the court filings for guardianship, essentially a recommendation to the court that the goals of care include hospice placement. Follow-up, the social worker informed the hospice liaison that the treatment team is moving forward with guardianship due to the inability to contact any of the patient's children. Court date June 30th, which is next week. However, a couple of days ago, the social worker received an email from the patient's daughter stating that she and her brother want to be the decision makers for the patient, and she would like to be named as the guardian as needed. In a subsequent phone call, the daughter said further endorsed wanting to be the guardian and that she and her brother are still wanting the patient to go into hospice care. So now they've decided to go into hospice care, and the daughter asked, what does she need to do to move forward with the hospice placement? So I don't know if so should we continue with the proceedings for guardianship with this new phone call? So I think that we should continue with guardianship because you never know when the surrogates will change their mind again. Now the court could absolutely pick the siblings as the guardian. No worries with that, and the court would say, okay, let's take the patient to hospice. And that will probably happen. And so now the care would be under the instructions of the judge in conjunction with the children. Okay. All right. So any final thoughts about that case?
Hey, Henry?
Yes.
This is Trish. So, my comment my question got buried in the hospice commentary. Do you mind knowing, and people may have been answering this, I wasn't sure what the no's and the yeses were too. Is there any relevant case law or further definition elsewhere that to define timely in a more definitive way? Or is it one of those where it's a little bit subjective, like what we think is a timely manner?
Also, the availability issue of surrogates.
Yes, exactly. Like to contact them in a timely manner. I don't know if there's ever a case that, if there's case law that would help us define that more, or if it's been defined more in some other way.
Right.
Eva.
So, right. I think the dog is trying to answer that question for me, but good question. The law could only do so much in unpacking the issues with a situation. Usually one would use the phrase good faith efforts, timely. I think if anything, sometimes we give it sometimes too much time to find the I get in touch with the surrogates. So, on one hand, it's not 24 hours. On the other hand, it's not a week. And so one has to use their best judgment regarding that. Let's see, anybody in the, if you have children who want to be guardian, right, yes, I just muted that person with the echo, Madeline. So I think in this case, even if we thought that the children was unsuitable to be a guardian, the judge will tell the children what they need to do. And so the children would still be involved, but they would be under the direction of the court, and that would be the reason to keep with the guardianship. Because it just appears that I'm not trying to deny that the children have been under a lot of distress, and initially they seemed they were wanting to do the right thing, and now they may be racked with guilt. Very complex, but first and foremost is the patient's best interest. All right, case 3 is another unusual case. What else is new? Does the patient have decision-making capacity? Patient is a 21-year-old female with unspecified psychosis, not due to substance disorder or known physiologic condition, who was admitted to psychiatry in May after being emergency petitioned by her family for aggressive and bizarre behavior at home. She was 36 weeks, 3 days pregnant at the time of admission without previous prenatal care. Patient was EP'd by her sister for peeing on the floor. I'm quoting what was an epic, on the bed, setting fires, animal abuse, using weapons against others. She allegedly kicked a dog and used a weapon to harm an adult. She hit her 9-year-old nephew and mother with an object, and she also, if that wasn't enough, she tried to set the house on fire in May. What else did we have here? So according to the notes, the patient found out she was pregnant in December and told the baby's father's grandmother then, but subsequently, she has denied that she was pregnant and refuses to acknowledge the pregnancy. Patient had been EP'd recently, also in January, that resulted in admission to Franklin Square Hospital, but after discharge, she didn't take her medications or follow her appointments. According to the chart, the further the patient has gotten into her pregnancy, the more aggressive she has been with her family. Patient lives at home with her mother, stepfather, 2 sisters, nephew, and the family dog. Since admission, the patient has remained disorganized. She does respond to internal stimuli. That was taken from the chart. Internal. I'm just looking at that word now, an internal stimuli. But anyway, she continues not to acknowledge her pregnancy, repeatedly stating, "I am not pregnant." Patient remains on constant visual observation for safety. The ideal timing for delivery has been discussed and decided it would be at 39 weeks and 0 days. The hope is that her mental status would improve and she would be able to participate in her care and have a vaginal delivery. Otherwise, the plan is for a scheduled C-section at 39 weeks with the consent obtained by the patient's mother. So would this represent a forced C-section? So let's have some discussion. What do you think about this C-section?
So I guess my first question is, what are considered to be the medical indications for a C-section in her situation? Is it felt that it would contribute to improving her psychiatric condition, or because it seems like there's not a typical obstetrical indication for like a scheduled C-section?
Well, the concern with the OB people is that she's denying her pregnancy, and she would not participate in the vaginal delivery with consequent harms to the fetus and herself. So the concern was whether she would be participatory in the vaginal delivery. She's denying that she's pregnant.
I have a question. I'm so sorry.
Yes, Miriam?
Before I was rescued by medical school, I was a social worker, a terrible job. And I had a case where the mother was similar to this, and they wanted to do a C-section because they were worried that she would have the baby unannounced and do something to the baby, which is what happened. She had the baby in her bathroom one day and then threw it in a trash can. So, and that was the fear that they had, and the reason that they were trying at that time, this is 30 years ago, to try to get a C-section.
Right. Okay. Well, thanks for that example. I think that amplifies the concern here that.
Can I make a quick comment coming from the pediatric side of this?
Sure, absolutely. Yeah.
If we were to attempt to have a vaginal delivery and mom isn't able or willing to fully participate, that could actually be much more dangerous for the baby. If, we have a baby that becomes stuck in the canal or soldier dystocia or something like that, and then it becomes much more dangerous to have an emergency C-section rather than a scheduled C-section for both mom and baby. So while I don't like taking, decision making away from this mom, if she does have what sounds to me like pregnancy-induced psychosis, then she's not really able to make appropriate decisions that would be healthy for both her and the baby. It's just my personal opinion, but take it for what it's worth.
Okay. It's worth a lot. Thank you very much. Okay. So, good. So the last few days, the patient has been pleasant and calm, and that's the way she looked when I saw her, but she was still denying her pregnancy. And now a hearing was scheduled for June 1st to review continued necessity of involuntary treatment in the hospital, and they called an ethics consult to review the case and give more validation for her remaining in the hospital. So I saw the patient. She was being monitored at that time for possible contractions. She was pleasant. Now she said she was waiting to be discharged. When I asked why she was in the hospital, she says she was in the hospital for allergies. I asked her questions about her abdominal pain that she was having at that time, and she again attributed it to allergies. I raised the possibility of her being pregnant, and she said, that is not possible. I do not have a partner. Okay. So should the patient involuntarily remain in the hospital? All right. Last voting. Get ready to vote. Should the patient remain in the hospital? Now, which of the following is the most important ethical principle? Okay, 100% said non-maleficence. That is exactly right. Okay, wow, 100%. And so here we have the voting, and congratulations, Michelle. And it's Now, why is it non-maleficence?
Am I the only one that voted?
Oh, so I have to, it could be. No, I think there's 2 people here. I have to give you guys more time. I just got introduced to this new polling mechanism here, and I apologize. I need to give you guys more time to vote. Okay, next time. All right. But anyway, so Michelle, you're on the, what's the phrase? You're on the whatever. Why?
On the spot.
On the spot, whatever. Why not?
I think the primary focus here is do no harm, and she is obviously not able to, like I said earlier, make decisions that are not harmful for herself and for the baby. So I think we need to protect her for her when she can't protect herself.
Right, exactly. So we're concerned about harm to her and harm to the fetus. And non-maleficence is the primary principle. And, you know, do no harm. And so, good. So the analysis, patient with history of bipolar, schizophrenia, schizoaffective disorder, now hospitalized for aggressive behavior towards the family members. Psych determined that she lacks decision-making capacity, although she does not vocalize now any belligerent actions towards self or others. A discharge to home would not represent a safe discharge insofar that at the time of delivery, let's say outside of the hospital, significant harms can occur to self and fetus. As she is denying she is pregnant, she is not appreciative of her medical condition. So let me fast forward here. So what happened was that so she remains a danger to self and fetus, and there was a hearing and a recommendation to continue involuntary treatment. She did deliver, and last week she had contractions, cervical dilatation, and now at that time, the patient was determined not to have capacity to refuse C-section. It disproves to be necessary. Fortunately, the patient did cooperate with the vaginal delivery, though I'm told at one point during the delivery, she said, am I really having a baby or something like that? But so on postpartum day 2, the residents asked the patient about long-acting implantable birth control. Initially, she said she was not interested, but the mom was in the room and said, we had talked about not being pregnant again, and at that point, the patient then agreed. So, does this patient have capacity to consent to, I'm not sure if I'm going to pronounce this correctly, Nexplanon? Does the patient have capacity to provide consent to the long-acting birth control? What are your thoughts? No, I don't think so. I have a lot of no's here. Why? Well, do you, according to the sliding scale of capacity, determination of capacity, would this be in her best interest? Do we need to have a high degree of certainty that she has capacity to give consent? Again, the sliding scale. Okay, her mom could give consent. yes. And maybe I'm trying to unpack this too much. But it's, we have a scale of no birth control, and then we have this used to be an issue about forced sterilization, which this is not, though it's on the same spectrum, though it's not forced sterilization. Right, sliding scale of capacity. So again, the sliding scale of capacity is that, so let me give an example. If you go into a patient's room and you want to get some blood, now getting some blood is in the patient's medical welfare to have that blood sample. And we don't do a capacity exam if the patient says yes. In fact, we may do one if the patient says no, or maybe not. But if the patient is making a decision that appears to be in their welfare, then we don't need to be all that certain that the patient has full autonomy, if that makes it better. Now, if the patient refuses the birth control, then that's a decision that goes against what we think is in the patient's best interest. And if the patient says no, then we want to be certain that the patient does not have capacity to say no, in which case then we would get the mom. So I maintain in this case that mom's consent is not necessary. The patient is saying yes. She's finally saying, oh, yes, right, I don't want to be pregnant. Let me have the long-acting birth control. It's another example. If the patient says no to intubation, that's harmful to their welfare, then we want to be more certain of the patient's capacity to say no. And if the patient gives good reasons why they don't want to be intubated, I lived a long life, I've been intubated before, blah, 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 then we would say a patient has capacity to say no. With these ethics rounds, we'll bring up some more cases. But let me end with the follow-up. Before discharge, psych said patient does not meet anymore the criteria for involuntary admission. She declined voluntary admission. Patient is able to be discharged from a psychiatric viewpoint. A newborn care plan meeting took place. Decision was made that the newborn would be discharged with the mom under the care of the maternal grandmother. Per psychiatry, patient did not meet criteria for involuntary admission and declined offer for voluntary admission. The patient was discharged home on postpartum day 2 under the supervision of the maternal grandmother. Telephone communications just the other day revealed that per the pediatric resident received a phone call from the pediatric office that mom was there screaming, cursing, appearing to be reacting to some internal stimuli. I get hearing voices, I guess. She then attempted to run away with the newborn. However, I guess the family, were able to take the baby and keep her safe. And after further discussion, there was the offer to call the police and maybe be EP'd by the police. And I think they were going to do that, but the patient ran away before the police arrived. Department of Social Services contacted by pediatrics office and gave instructions to leave the baby with the father of the baby. It's just a lot of angst going on here, if I could use that word. Any final thoughts? I had another case, but I'll save that for next time. And let me just say thank you very much. I know I went over time. Thanks for remaining. Any final thoughts about that last case? Yes, heartbreaking. I agree. I don't know what's going to happen with her.
Would she now meet the criteria for involuntary hospitalization?
That's a very good question. I think so. I think she's continues to be a harm to herself and other people. And I'll keep on looking at follow-up to see where she presents. And I don't, she was on a drug treatment plan, even back in January, but she was discharged, didn't take the medicines, didn't go for follow-up appointment. It appears that she needs to be involuntarily committed. Other final thoughts? Right. Bill, who are you to make the determination what's in the patient's best interest? Let me, you raise a good point. To be sure, the sliding scale of capacity is paternalistic. I'm not going to deny that. And capacity determination is, of all the things we do, that is very could be very ambiguous and needs to be done in conjunction with other people, because Bill, you said, who are you to make that determination? And I agree. No one person should do that. It should be in conjunction with I was going to say, I'm searching for the right word, interprofessional team, and ideally be broad-based. Unfortunately, sometimes in the heat of the night, one does not have the time or the resources to gather up a group in emergency situations. And it just begets the larger issue of how we make decisions, and more importantly, how do we have accountability, and how do we review the decisions that we make? And so actually, I find, we present these, we try to have these cases in conjunction with other members of the ethics team. We do retrospective review of the cases at our monthly meetings. And actually, I find presenting these cases in this forum, the ethics rounds, and hearing what your thoughts are as well, as very useful in how we make these decisions. And again, I agree, this sliding scale, which I hope to further unpack, it's not my sliding scale. It's something that's been explored in the literature. That doesn't make it the best way, but determining decision-making capacity is one of the hardest things we do in medicine. Thank you for that thought. Any other final thoughts? Okay. All right. Well, thanks again for your thoughts.